The terminology of lacrimal diseases is basically revolving around the lacrimal apparatus. So lacrimal apparatus is basically consisting of the lacrimal gland that is located slightly lateral to the orbital cavity. And then basically we have the two canaliculi that are located medially near to the medial wall of the orbital cavity that is near the nasal cavity. So we have basically a lacrimal gland. We have two canaliculi that are basically draining into the lacrimal sac, and then we have a nasolacrimal duct that is opening in the inferior meatus of the nasal cavity. So this is the whole lacrimal apparatus that we're going to talk about. Any congenital abnormality that is pertaining to any of the structure of the lacrimal apparatus or any infectious diseases that can arise in the lacrimal gland itself, or either it can involve the ducts of the lacrimal gland, that can be the any one of the canaliculi or the nasolacrimal sac itself, or the nasolacrimal duct, or the opening of the nasolacrimal duct. Any of the infectious states that arise in any of these structures can basically relate to the lacrimal diseases. Now we have basically a particular set of clinical symptomatology that are relating to the diseases of the lacrimal apparatus. For that, we should know the functioning of the lacrimal gland. In layman terminology, the lacrimal gland is responsible for the production of the tear film. It's basically known as the precorneal tear film that is present anterior to the cornea. It is involving the conjunctiva as well. And it's basically bathing the conjunctiva as well as the cornea. So it's basically this thin tear film that is present upon the conjunctiva and the cornea that gives off that lustrous appearance to the eyeball. The composition of this precorneal tear film is quite interesting. It's basically involving the aqueous layer, which is almost 7 micrometers in the thickness. And then we have the thinnest layers, that is, we have a mucus layer, and then we have a mucoid or a fatty layer on the other hand. The thickness involving the most outermost layer, it's almost 0.1 micrometers, and this lowermost thickening, that is the basement membrane, it's almost 0.2 micrometers. So this is how the precorneal tear film is being composed of. The formation of this tear film is the responsibility that is being subjected to the lacrimal gland. When we just recall the anatomy of the lacrimal gland, it has an orbital part and it also has a palpebral part, which is in close relationship to the eyelids. So both of these lobes of the lacrimal gland are responsible for the production of this tear film. It can be any congenital abnormality that is relating to this particular lacrimal gland, as well as the drainage of this tear film, because there is a continuous production of the tear film by the lacrimal gland. It has to be drained off, just not to overflow the conjunctival sac. If there is an overflow of the conjunctival sac, that means that there is some sort of a problem with the drainage system. The drainage system of the lacrimal apparatus is being composed of the canaliculi. We have an upper canaliculi and a lower canaliculi, and they're basically draining off into the nasolacrimal sac. Now, the backflow of this tear film or this drainage system is prohibited by the different valves that are present in the canaliculi, as well as these valves are present in the nasolacrimal duct. And it's basically the most important gland or the most important valve that is present in the nasolacrimal sac is the valve of Hassner that is present in the nasolacrimal sac, and it prevents the backflow of the tears back into the conjunctival sac or back into the canaliculi. And again, this lacrimal sac is going to drain into the nasolacrimal duct opening, which is present in the inferior meatus of the nasal cavity. Now, just to give you an overview of the lateral wall of the nasal cavity, we have a superior, we have a middle, and we have an inferior turbinates. These are basically bony projections that are present on the lateral wall of the nasal cavity. They are very important anatomical features because we have to clinically correlate between different openings that basically drain into the nasal cavity and what are the different pathological features that can arise in these openings. One of the most important openings is in the inferior meatus of the nasal cavity. It's basically behind the most lower formed turbinate that is present in the nasal cavity. It's the inferior meatus, and there we have an opening for the nasolacrimal duct. So if there is any blockage or if there is any obstruction in this opening that is basically opening up into the nasal cavity, again, there was going to be a backflow of the tear film, and there would be features of excessive lacrimation or outflow of the tears from the conjunctival sac. So what would be the common signs and symptoms that you would observe in a patient who is suffering from any lacrimal disease is again very important. The most important terminology that you have to remember over here is epiphora. Epiphora is basically the terminology which is given for the excessive lacrimation and is basically characterized by the outflow of the tear film from the conjunctival sac. So this is the most important complaint that the patient would give you, or would give you the history regarding the epiphora that he has been suffering from. And then obviously you would ask the patient about the time since he has been suffering from this sort of an epiphora. If it's a child, we can even ask, or we can even investigate the patient whether it is some sort of a congenital problem that the baby is suffering from or not. So these would be the particular features of a patient who is suffering from the lacrimal gland disorder. So over here, you can just observe the composition just by the fact that the outermost layer is in close contact with the air, that is the environment. We have a superficial oily layer, we have an aqueous layer with it, which is basically a diluted mucin that is present over here, and then we have a mucoid layer. The most thickest of all of these layers, if we compare them, is the aqueous layer that is forming the main component of the tear film over here, and then we have obviously the corneal epithelium, which is in close contact with the mucoid layer of the tear film. So this is the basic composition, just to give you the important anatomical features over here. Then the lacrimal drainage system. As I've already mentioned, we have a lacrimal gland that is present just slightly lateral to the orbital margins. So this is the orbital part of the lacrimal gland, and then we have the palpebral portion of the lacrimal gland that is present over here. And then obviously the tear production starts off from here. The tears are going to get into the conjunctival sac, and then we have the upper canaliculi, we have the lower canaliculi over here. We have the small puncti that are present on this medial border that are basically indicating that these are the lacrimal duct openings over here. They are both communicating, and they are draining into the nasolacrimal sac, and this nasolacrimal sac is then draining into the nasolacrimal duct. If you just have a look at this nasolacrimal sac, there is the fundus over here. This portion is majorly known as the body of the lacrimal sac, and then we have the neck of the nasolacrimal sac. So these are the three anatomical features that are pertaining to the lacrimal sac over here, and they are basically a part and parcel of the lacrimal drainage system over here. The lacrimal gland is present over here, and we have the puncti, we have the superior lacrimal canal, the tear sac, the inferior lacrimal canal, and the inferior lacrimal puncti. Now, these puncti are again very important because whenever we're going to perform the probing procedure, just to open up these canals, we should know that this is the surface anatomy for the canaliculi, that is the superior lacrimal canal and the inferior lacrimal canal, and we can enter these canals through these puncti that are present medially. So knowing this feature is again a very important clinical correlation in between, when that is basically the final nasolacrimal canal. Now, the palpebral portion of the lacrimal gland is again very important because that is responsible for draining the tear film into the conjunctival sac. Any infectious states can arise and they can move on from the sclera to the palpebral portion of the lacrimal gland. Infections can even travel from the nasal cavities or from the conjunctival sac, the conjunctiva itself. For example, the different cases of conjunctivitis, for example, trachomatis, syphilis, Staphylococcus pneumoniae, streptococcus, all of these can basically infect this palpebral portion of the lacrimal gland. And these infectious states will have their own clinical features. That is basically the inflammatory features. They'll basically pertain to the catarrhal features whenever this palpebral portion of the lacrimal gland is infected. So there are different tests that are performed whenever we want to test whether the lacrimal gland is performing or functioning in a normal manner or not. We have the different staining tests that we can perform for this functioning processes, as well as we have the Schirmer's test, which is one of the pathognomonic tests that is performed just to evaluate the normal functioning of the lacrimal gland in an individual. What is basically happening over here is we just put in filter paper that is almost 35 into 2 millimeters in length. That is the width and the length of this filter paper, and we just place this filter paper into the lower conjunctival sac, into the lower fornix. Then we ask the patient to look upward, and we just keep that filter paper, and we just basically ask the patient not to blink during this procedure quite abruptly, because that is going to increase the lacrimation process. After just about 15 to 20 seconds, we're just going to evaluate the amount of the tear film that has been absorbed by the filter paper, and that is going to be almost 5 to 10 centimeters. That is the normal ranges in a normal individual who is producing a normal tear film, not excessive or not the lowest amount of the tear film that is being produced. So it can be a dry eye syndrome that can be diagnosed by this Schirmer's test, and on the other hand, even it can be a watery eye syndrome that can be diagnosed by this Schirmer's test. So it's basically a very common procedure that is being performed in the that can be easily performed in the outpatient departments, and we can evaluate the functionality of the lacrimal gland apparatus through this testing procedure by ourselves. Now, there are a lot of staining techniques, as I've already mentioned. The most significant of this staining is the rose Bengal staining. So we have basically 3 categories. Over here, we have the A, B, and C category over here. So it's basically, if it's a dry eye, we have the severities being described as mild, moderate, or severe. So it can, if it's just a little uptake of the staining, that is basically categorizing a type A dry eye syndrome, and then we have a type B, which is characterizing the mild severity of the dry eye syndrome. And then we have the type C, that is basically categorizing a type C dry eye syndrome. Dry eye syndromes, just to have a look at this terminology, they are also known as KCS, that is the keratoconjunctivitis sicca. So it's basically a terminology that is used for the dry eye syndromes. On the other hand, we can further classify these dry eye syndromes into Dodgen syndrome, which is a syndromic condition, and along with the dry eye, there are the particular other features that are accompanying in that particular individual. We have a primary dry eye syndrome or a primary Dodgen syndrome, and then we have the secondary Dodgen's syndrome that are basically secondary to the other infectious states of the eye. For example, it can be the infections that are being caused by the trachoma, by the syphilis, then we have the viral infections, then we have the bacterial infections. So all of these can basically lay the foundation towards the development of Georgian syndrome or the dry eye syndrome in the individual. The functionality of the lacrimal test can furthermore be just evaluated by a series of other tests that can be performed for this purpose. Along with this, the staining techniques that we've already performed, along with the Schirmer's test that we've already done with, we can perform the fluorescein dye testing in a lot of individuals. What is basically happening over here that we are inserting this particular stain, and that is going to be taken up by the punctate basophilic ulcers if they are present on the corneal epithelium of the individual. So this punctate basophilia is being evaluated in these individuals after we perform this fluorescein dye test in these individuals. Then we can perform the digital subtraction dacryocystographies. Now, they can be even just by injecting this kind of this a particular dye in the lacrimal apparatus, and then just observing if there is any blockage or if there is any obstruction in the drainage system or not. And then we can even just evaluate the exact location of the obstruction in the drainage system by this technique of the digital subtraction dacryocystography. The lacrimal sac is filled with the contrast medium over here. And that is basically the contrast medium is going to evaluate whether the obstruction is lying in the lacrimal sac or if there is some sort of excessive lacrimation that is the reason for the outflow of the tear film in the conjunctival sac. The dacryocystograms are being evaluated. A lot of techniques are being, we have different radio imaging techniques that can be performed, and that again are going to just evaluate or just to give you the features of the obstruction in the lacrimal apparatus. This is one of the dacryocystogram that is being performed that over here. Basically, there is an injection of the dye, and after that we perform this dacryocystogram just to evaluate any obstruction in the lacrimal sac or if there is any sort of a problem in the valvular system of the lacrimal sac that is allowing the backflow of the tears back into the conjunctival sac. Apart from the different features in which we have the excessive lacrimation, in which we have the dry eye syndrome, on the other hand, we have the watery eye syndromes, both of which can be basically part and parcel of the lacrimal gland. But again, it can be the nerve supply that is responsible for the excessive lacrimation. So whatever the cause is, we should know that the dry eye syndrome or the watery eye syndrome can be caused due to the central causes as well, because we have the excessive lacrimation, we have the primary excessive lacrimation, we have a reflex lacrimation system. And then on the other hand, we have the central lacrimation. Basically, we have the salivary nucleus, so we have the lacrimation nucleus lying in the central nervous system, and that is being communicated to the pterygopalatine ganglion. And then again, it is conducted by the fifth cranial nerve. This is the nerve supply of the lacrimal gland. So if there is any sort of an abnormality within this nervous system or within this pathway of the messages, even then there can be an excessive lacrimation, or even then it can be a decreased lacrimation that is observed in this individual. So these can be the causes, or this is how basically you remember the different causative factors, the classification of the etiological factors. Whenever you have this question in your mind, you have a patient of excessive lacrimation, or you have a patient of a dry eye that he's suffering from, this is the basic etiological classification that you have to keep in your mind. On one hand, it can be a primary excessive lacrimation. We can have a secondary excessive lacrimation due to infections or other states of the eye. And then we can have the central causes of the excessive or a decreased lacrimation. This is the easiest way to remember this, the etiological factors towards the development of the lacrimal diseases. When we are listing down the different sorts of the lacrimal diseases, one of the most important is the dacryoadenitis, in which the gland itself is infected. So there would be the multiple factors for the development of this infectious states. It can be the frequently infectious, or typically it is usually unilateral. The viruses, they can be involved. Acute non-suppurative dacryoadenitis is one of the causative factor. And then we can have the chronic cases, the chronic inflammatory cases. It can be an infection. That is basically, the chronic infections are usually multifactorial. The person would be suffering from the infections as well as he would be suffering from some structural abnormalities. For example, there would be some blockage in the drainage system as well. And that would basically be superimposing the picture in this individual. Then we have the IgG4 related dacryoadenitis, that is basically an autoimmune reaction that is noted down in these individuals. Now moving on to the histopathological features for the dacryoadenitis, we have the inflammatory features. The cell-mediated immune response is very important over here. The non-specific inflammation of lacrimal gland is observed in this type of inflammation. The infiltrates would be consisting of the lymphocytic, or either it can be mixed with the neutrophilic infiltration. And the staining would be increased because of IgG4 positive plasma cells that would be included in this kind of a dacryoadenitis state. The diagnosis of dacryoadenitis is made upon by a lot of factors. First of all, there is an acute kind of dacryoadenitis, and on the other hand, we have chronic dacryoadenitis. Acute would be already encompassing almost 2 to 3 days, and there would be a full-blown picture of dacryoadenitis. There would be the features of irritation that are observed in the eye. There would be excessive lacrimation that the patient is suffering from. Mild irritation in the eyes, photophobia. All of these would be the feature of acute dacryoadenitis that the patient has developed in almost a time period of 2 to 3 days, not more than that. So in cases of chronic dacryoadenitis, we'd have the different features in which the time duration would be almost more than 3 weeks. The spear of discharge from the eye examination is sent for just the histopathology. The blood cultures are taken, and the culture of the discharge is also very significant over here, just to identify the causative organisms. The list of organisms would consist of chlamydia, streptococcus pneumoniae, staphylococcus organisms. In chronic dacryoadenitis, we'd perform the biopsies, that is the lacrimal gland biopsies, very critical over here. The treatment would obviously consist of the oral antiviral medications that are given to the patient, then obviously the systemic antibiotic therapy. This can be a prophylactic antibiotic therapy, even if there is no bacterial infection that the patient is suffering from. It can be a prophylactic therapy that is given to the patient just to negate the formation of a superimposed bacterial infection in this individual. Then the use of the corticosteroids and the radiotherapy is even more critical over here. In cases of acute dacryoadenitis, the patient would be suffering from a discharge that he would be complaining of. In a lot of patients, the patient would basically complain of thin watery discharge. But if there is a superimposed bacterial infection, or if it is a superimposed viral infection, or even if an allergic reaction has been started on, process has been started on, then the patient can have a mucopurulent discharge as well in these cases. The time duration for this infection would be almost 1 to 2 days. In cases of chronic dacryoadenitis, there would be the chronic features. There would be the swelling of the lacrimal gland that is quite feasibly observed in these individuals just upon closing the eyes and just upon the complete inspection of the individual. It would basically reveal that the patient has been suffering from a chronic infection pertaining to the lacrimal gland, excessive lacrimation, the swelling of the gland, the mucopurulent or the superimposed bacterial infections are quite vividly present in these kind of individuals. The tumors of the lacrimal gland can also be observed in a lot of individuals. It can be even the benign tumors that the patient can be suffering from. And on the other hand, we can have the chronic or the malignant tumors that the patient can be suffering from. Again, it is going to be the biopsy that is going to reveal the final diagnosis in the individual. Whenever the patient again would give you a history of excessive lacrimation because there's going to be a tumor of the gland, so there is going to be an increased outflow of the lacrimal film that is being formed by the lacrimal apparatus. Again, the drainage system can be affected, or there can be the superimposed infections in this kind of a state, and that is going to complicate the picture in these individuals. The final diagnosis would be after you perform the baseline investigations in these individuals and you send the histopathology for the final diagnosis in this kind of individual. Obviously, we'd perform just not the biopsy test. It would be pertaining to the radio imaging, that is the CT scans and the MRIs, just to know the depth and any collateral damage that has been caused by this kind of a lacrimal gland tumor. It can be due to the pressure symptoms that are being produced by such sort of a lacrimal gland tumor, or it can be some sort of metastasis that has occurred to the anterior cranial fossa or the structures of the middle or the posterior cranial fossa. Can be involved in a lot of cases because there is a communication between the anterior cranial fossa, the orbital cavity, and the structures of the orbital cavity are in close relationship with the structures that are present in the anterior cranial fossa due to the fissures, that is the superior orbital fissure and the inferior orbital fissure. So there can be the cases of metastasis that are observed in a lot of cases. Then we perform the tear film breakup. This is one of the tests that is being performed and just to check the functionality of the lacrimal gland apparatus again. We can just observe the cases of the chronic dacryoostenosis. Stenosis is a feature that is congenital in most of the cases. In a lot of cases, it can be an acquired feature as well, but usually it would be the babies, the newborn infants that would come up to you, and the parents would basically give you a history of the excessive lacrimation. Superimposed infections are going to be present in these infants very oftenly. History taking is again very important over here because that is going to reveal that what can be the causes towards this excessive lacrimation that the newborn is suffering from. We can have the differential diagnosis of ophthalmia neonatarum or other congenital abnormalities as well. But this would be one of the causative factor, that is the chronic dacryoostenosis, that is in which there can be a stenosis of the nasolacrimal duct, the nasolacrimal sac, or it can be the stenosis of the canaliculi. So basically the drainage system is affected in these newborn infants. The treatment would be obviously to, first of all, it can be a symptomatic treatment if it is of a mild intensity. We can just offer a symptomatic treatment and we can apply a wait and watch strategy in milder cases. But if it is a severe case of stenosis, we can perform the probing techniques and the final DCRs can be, that is the dacryocystogram can be performed in these infants as well. Then in a lot of cases, apart from the infections of the canalicular system, apart from the congenital abnormalities of the canalicular system, we can have trauma as one of the major factor. Tumor is one of the factor, tumorous conditions, and as well as the traumatic conditions that can arise in the inferior canaliculi or that can arise in the superior canaliculi. Any orbital surgical procedures or histories of the orbital surgeries would reveal that the patient is suffering from some sort of a trauma towards the inferior canaliculi. Again, I would like to emphasize on this factor that the history taking is very important in these cases of the lacrimal diseases. Age is very important in the chronic diseases. Usually the age group of the 4th to 6th decade are more prone to the development of these canalicular diseases. Females are more predisposed to the development of these stenotic conditions because they already have a stenosed or a narrower duct as compared to the males. So they are more prone to the development of these stenotic conditions. Age, we have the sex or the gender of the individual, then the family history, the socioeconomic status of the individual, and the environmental conditions, the personal hygiene. So all of these would be the questions that you would ask from the patient, and that are basically going to reveal the different factors, the different etiological factors towards the development of the dacryoadenitis. Trauma, basically the history when you're taking the past medical and the past surgical history, that would reveal any recent orbital surgical procedures that have been performed or any retrobulbar injections or any history of such injections. The intubation of the lacrimal canaliculi is one of the treatment modalities that is being performed in such cases. And that is basically going to reveal the condition or relieve the patient of that excessive drainage. Basically, the drainage system is distorted and the lacrimal apparatus is being distorted. There is an excessive lacrimation. So this condition can be improved by just intubating the lacrimal canaliculi. We also perform some balloon cathetering techniques in the canaliculi just to open up the drainage system. We can perform the probing techniques in these patients whenever we have a patient of trauma or whenever we have a patient of congenital stenosis and he's suffering from this kind of a picture. Now, cases of the acute dacryocystitis would basically relate to such a picture. As you can observe in this individual, obviously the history would reveal the factors that he had been suffering from any acute or any chronic state of lacrimal diseases, and that basically resulted in this kind of a cyst that he would present with. The examination of the cyst is again important. Whenever you have this patient, you will examine the inspection, the palpation, the history taking would reveal the further aspects of the disease, and obviously the drainage of the cyst would be important over here. First of all, there would be incision and drainage that you would observe in these patients, and then you would finally investigate what is the basic cause that related to the formation of such dacryocystitis condition in the patient and led to such a picture. And then only after giving the symptomatic treatment, you would get the topical antibiotics. You would obviously couple up the systemic antibiotics along with it, and there would be this complete picture. It's basically a complication of dacryoadenitis that has occurred. Then we have cases of acute dacryocystitis even in the children. Usually in the children, you would suspect some sort of a congenital disease or congenital stenosis that the patient can be suffering from, and that led to the formation of this acute dacryocystitis in the child. In the adults, obviously, the risk factors are quite different. It can be the environmental factors, the poor socioeconomic status, and the poor hygienic factors are very important over here. This would be the picture of acute dacryocystitis in the adults. So it's basically the cystic formation over here relating to the medial wall of the orbit, and that is basically going to highlight the factor. It's the lacrimal apparatus. Why not the nasal cavity, or why not any of the glands, that is the meibomian glands, that can be responsible over here? The glands can be the glands that are responsible for the mucus formation of the tear film are the glands of the cross and the glands of the Wolfram. So even these glands can be investigated over here whenever we have the cystic formation. We can just suspect that it can be one of these glands, that is the glands of cross or the Wolfram, that are being infected or that are being inflamed, and they are giving this particular kind of a picture. But the particular historical features would basically differentiate the situation. The patient would give you a history of previous episodes of dacryoadenitis, or either he or she would be suffering from chronic dacryoadenitis. Even the further investigations would reveal the picture of any tumorous conditions or even any traumatic conditions that can relate to the lacrimal apparatus of the individual. For example, previous history of any surgical procedures that has been performed on the orbital cavity or the orbit. They are basically the risk factors towards the development of this dacryocystitis conditions in the adults. Again, the poor socioeconomic features would be one of the risk factor. The environmental conditions can even further superimpose the conditions and further basically prone the patient towards the development of this cystic lesion that arises in the lacrimal apparatus or that arises in the canaliculi of such individual. Now, in cases of severe acute dacryocystitis, we have basically these two varieties. Either it is a normal cyst that is not superimposed with any infections, or either it is quite a severe picture in which there are superimposed infections, the cyst is basically larger in size. It's an acute condition that has been that the patient presented with. He or she would not give you any chronic history. There won't be any slow progression of the inflammation. There would be this picture of the cyst that he would present with, and the history would be almost of a 1 day or a 2-day duration. So this would basically encompass a severe acute dacryocystitis. Obviously, the treatment modalities are quite different when we are dealing with a severe variety of dacryocystitis, and on the other hand, with a mild or a moderate variety of dacryocystitis. We can just perform the supportive treatment for the milder forms, whereas on the other hand, if it is a severe variety of dacryocystitis, we have to intervene, and we have to perform the surgical procedures, the incision and drainage, give systemic antibiotics to the patient, and all of these are basically going to relieve the patient of the particular symptoms that he or she has been suffering from. The different treatment techniques that are available out there, we can perform obviously the topical treatments, the topical antibiotics, the systemic treatments that is basically pertaining to the antibiotics, the steroidal therapies. On the other hand, there is this most important surgical procedure which is known as the dacryocystogram. So if it's a chronic case, or if the patient presented late to the outpatient department or to the doctor, we can perform this technique just to open up the canals. Before that, we would perform the probing techniques, or we would try to imply the catheter balloonizing techniques, in which basically there is a way in which the canaliculi are dilated by a balloon catheter that is injected into either of the puncti. So it can be one of the techniques just to open up the drainage system, but over here we are referring to the dacryocystogram. So as the name is indicating, it's just not the opening up of the lacrimal apparatus, it's the opening up of the nasal cavity, the turbinates are opened up, and even they are evaluated for any surgical procedure that can be performed just to enhance the drainage system in these individuals. This procedure would consist of simple steps, raising the flap and then performing the corrective surgeries, and then just performing the cosmetic procedures to finalize the procedure. So it's basically the most important technique that is the mainstay towards the management of such cases of lacrimal gland diseases, or the patients who come up to you in the chronic states of dacryoadenitis or dacryocystitis. So these can be the treatment modalities that are performed. The terfination of the bone, that is the turbinates, as I've already mentioned, they are anastomosed. The nasolacrimal duct is anastomosed, and this is basically the nasal cavity. So the nasolacrimal sac lies in close contact with the nasal cavity, so we can approach this sac through the nasal cavity, opening the nasal cavity and approaching the sac and performing the anastomosis. So these would be the particular steps out here. This is when we perform this dacryocystostomy on a patient. This is how you do it. This is how you approach the lacrimal sac through the orbital cavity. You open up the lacrimal sac and you approach it, and you just see whether there is any sort of an obstruction or if there is an infectious state. You just drain and incise that area, and then you just close up the flaps and perform the anastomosis in these patients. This is the complete drainage system or the lacrimal apparatus that we have been talking about, consisting of the nasolacrimal gland, the puncti, the lacrimal sac, and the nasolacrimal duct. And finally, there can be obstruction in this at any level. It can be the canaliculi, it can be the sac that is being obstructed, it can be the neck of the sac, which is most prone towards the obstructions, and obviously it can be the major duct that can be obstructed. So whatever the level of obstruction is and whatever the cause or the etiological factor for the development of the obstruction is, we have to relieve the patient of this obstruction just to have the normal outflow of the tear film, and just to avoid any sort of excessive lacrimation in these individuals. So we usually get a lot of children with this nasolacrimal duct obstruction. It can be any sort of a congenital problem that the child may be suffering from. And if it's some sort of leg ophthalmos that that is one of the causative factors towards the excessive exposure of this tear film with the environment, and that is basically relating to the dry eye syndrome in these individuals. So whatever the etiological factor is in the children, you have to just relieve the patient of that final etiological factor or the baseline towards the development of this nasolacrimal duct obstruction or this excessive lacrimation. The obstruction is one of the cause of the excessive lacrimation, but you have to evaluate and you have to properly investigate the child just to get to know what is the baseline cause or the baseline etiology towards this excessive lacrimation that the child is suffering from. If it's some sort of a stenosis, you have to relieve it, and you have to perform the surgical procedures to relieve the patient of this particular kind of a situation. So in this lecture, we tried to summarize the different conditions that can arise in the lacrimal apparatus. These conditions can broadly be classified into the congenital and the acquired conditions, the acquired infectious states of the individual. How do we manage these cases of the infections? And if it's a complicated case of the dacryoadenitis, how do we deal with it? All of this is being discussed over here. So that is the end of this lecture. Thank you for watching sqadia.com.